Hi, it's Dr. Silva. Thank you for joining me for this talk on the Prozac family of medications. I call it the Prozac family because Prozac was the prototype. It was the first SSRI that was approved for use in the United States. And this is probably the most commonly prescribed class of antidepressants today, probably still. They are the selective serotonin reuptake inhibitors, the so-called Prozac family of medications. And they include Prozac, Zoloft, Paxil, Luvox, Celexa, and Lexapro. Venlafaxine Effexor is essentially an SSRI at low doses. It's only significantly noradrenergic, blocking the reuptake of norepinephrine when you get up into higher doses. But at all doses, it blocks the reuptake of serotonin more so than norepinephrine. That's also true of Cymbalta, duloxetine, the other modern SNRI. But today I'm just going to talk about the SSRIs. So they are widely prescribed because they're safe and they're generally well tolerated. They're also highly effective at improving a person's mood and reducing symptoms of tearfulness, hopelessness, irritability, and anxiety, including panic attacks, obsessions, and compulsions. Those symptoms specifically, as opposed to other medications that block the reuptake of other neurotransmitters that target other symptoms. So because they all share the same mechanism of action, increasing the bioavailability of the neurotransmitter serotonin by blocking its reuptake, when a neuron releases serotonin into the synapse where it is active by communicating with the serotonin receptors on the postsynaptic neuron. One way that serotonin's actions are terminated is the same neuron that released it takes it back up, vacuums it back up, and it does that through a transporter, a serotonin transporter. If you block that transporter, then you increase the concentration of serotonin in the synapse because you're just not clearing it away. One of the mechanisms is hindered, and you thereby increase the actions of serotonin. So you can do that by using a serotonin reuptake inhibitor, SSRI. The first S stands for selective because these medications are fairly selective. They do hit other receptors, but compared to the first generation of antidepressants, which were also SNRIs, they have both mechanisms. They block the reuptake of serotonin and norepinephrine, like Effexor and Cymbalta, venlafaxine and duloxetine, respectively. Those first generation agents were also antihistaminergic. They blocked histamine receptors. They were anticholinergic, blocking muscarinic acetylcholine receptors. They also blocked alpha adrenergic receptors, which were norepinephrine receptors, and a bunch of other receptors. So they were so-called dirty drugs. Here we had a class of medications that were selective to the serotonin transporters. So they were selective serotonin reuptake inhibitors, SSRIs. And they're all remarkably similar with respect to how they help, as well as in regard to their side effect profiles. This is because, by and large, it's the increase in serotonin itself that's responsible for both the beneficial effects on the brain as well as bothersome physical effects that occur elsewhere in the body, such as the GI tract. It is serotonin that's causing these effects, and not the Paxil molecule, not the Prozac molecule or the Zoloft molecule. There are various types of serotonin receptors, and they're widespread throughout the body. And by the way, serotonin is considered a neurotransmitter when it's communicating between neurons in the central nervous system. But when it's released by an organ and it acts at a distance, well, that's the definition of a hormone. Serotonin is produced in the brain in the raphe nuclei, which are located in the midline of the brainstem. When serotonin is released and then acts on serotonin receptors in the gut, for example, then it's acting as a hormone. But interestingly, there's more serotonin in the gut than there is in the brain. About 90% of the body's serotonin is found in the cells lining the gastrointestinal tract. Only about 10% of the body's serotonin is produced in the brain. Practitioners are often fond of saying that the choice of an SSRI is an empiric one. that starting an SSRI for the first time, making dosage adjustments, resuming therapy, and or switching to a new or different medication within this class is essentially a trial and error process. But that doesn't mean that it's completely arbitrary or haphazard, although some prescribers do tend to approach it that way, unfortunately. Educated guesses can be made before a medication trial is undertaken. If not regarding how useful a medication's effect on an individual's mood will be, then at least with regard to how well or how poorly it will be tolerated. And you don't need expensive pharmacogenomic testing, by the way, to tell you that. Yes, those tests can identify slow metabolizers or people that may be especially sensitive to one medication or another. I do a whole other video on this, but you start with a low dose and you titrate slowly. Start low, go slow, right? Especially in the elderly and in children and in people that are already on other medications where you might have a synergistic action. You start with a low dose and you go slowly and you take it with food and you divide the dosage and you do everything you can to minimize side effects. You don't need expensive blood work to tell you. I just think that's a huge waste of money, but especially since those tests can't predict efficacy. We can't predict who's going to have a favorable response. We can predict which target symptoms will be diminished by increasing serotonin, and that's practically guaranteed. It's just a matter of degree. And there are so many other variables that impinge upon whether or not a given treatment is going to help. There are non-pharmacological variables. Are they abusing substances? Do they have a personality disorder? What's their social support like? Are they getting enough sleep, nutrition, etc., etc.? So you can never predict efficacy. But mindfulness on the part of the prescriber, as well as the person agreeing to subject themselves to a trial of this type of medication, can avoid a lot of wasted time and an unpleasant experience. So, how best to choose among this family of medications? Well, of course, your doctor will be making the final decision, the final recommendation rather. But with regard to treatment with an SSRI, there's never only one option for a patient. So your doctor should be giving you options. And ultimately, it will be your decision. And unless you've tried them all, and usually even patients that tell me they've tried them all and none of them work, they really have not had an adequate therapeutic trial of every medication, because an adequate therapeutic trial means taking the right dose for weeks to months. And most patients will abort medication trials, especially the ones that have tried them all. They will abort usually long before they get to a therapeutic trial. So assuming this is the best class of medication from which to choose, there are two main considerations. Number one, selecting a medication that's likely to work, and two, selecting the medication that will best be tolerated by the patient. Because the SSRIs are more or less equally likely to work, I'll say that again, the SSRIs are more or less equally likely to work. Ultimately, this decision is more often based on the second consideration. Remember that it's serotonin that's coming to the rescue, after all. And so if you dose the medication properly and you're patient and you attend to all of the other variables, then serotonin is going to increase the threshold for tears and increase the threshold for panic and irritability, etc. So your target symptoms are going to improve if we increase serotonin. So assuming there are no extraneous variables that are impinging upon the treatment, you're going to get improvement. But whatever those extraneous variables may be, if you're smoking crack on the weekends, it's going to have the same impingement on Zoloft as it will on Prozac, as it will on Paxil. And so ultimately, they're more or less equally likely to work. Now, in practice, one medication is often better for a given patient than another medication, and we may never know why. Psychogenomic testing is not going to tell us why. We can look at the family history. If your sister did really well on Prozac, but not so good on Paxil in terms of efficacy, then that is something we look at because you share approximately 50% of your DNA. Or if you have an identical twin, that's even better. But otherwise, that's more of an empiric trial. We just have to kind of try it out and see. Assuming that the diagnosis is correct, and that medication management is indicated in the first place, and that the target symptoms in question indicate that an SSRI would be the best initial option, i.e. agitated, irritable depressions, and/or anxiety states, they all start out with the same likelihood of helping. Differences in efficacy are idiosyncratic, that is to say, they depend largely upon the individual who's taking them, and they do so for unknown biological reasons. And so we try one medication to see if it works, and we ensure that a good therapeutic trial is completed before trying something else, if necessary. However, what I've found in my practice is that switching from one SSRI to another is not usually because of a lack of effectiveness. I very rarely have a patient come back to me and say, it's not helping at all. Instead, having to switch is usually due to tolerability issues. By anticipating these tolerability issues, which is more methodical than anticipating efficacy, and again, which does not require pharmacogenomic testing, time and frustration can be saved. Selecting the SSRI that will best be tolerated by the patient. Okay, while the reasons for differences among individuals in terms of efficacy is a mystery, differences in tolerability can often be explained and even predicted. If you reviewed the complete prescribing information for any of these medications, you'd be left with the impression that all of them can cause all of the same potential side effects, which is true. But the clinical reality is that some of them are much, much more likely to cause certain side effects than others. All you need to know as a patient is that one SSRI tends to cause more diarrhea or constipation or dry mouth than another, or that a given SSRI tends to cause more weight gain or more sexual dysfunction than the others, etc. Likewise, if you read the pages and pages devoted to each medication in the PDR, the physician's desk reference, you'd come to realize that nearly every side effect known to man has been reported at one time or another, or associated in some way or another with every known medication, rendering an encyclopedic book like the PDR practically useless to the individual who just wants to know which side effects are likely, not which ones are possible. There are only a handful of truly common problems. When I first started routinely prescribing these medications in the mid-90s, there were only 4 available SSRIs in the United States. But even then, I had no idea how Prozac would be different for a patient than Zoloft, or Paxil versus Luvox. Now, after having prescribed these medications for more than 2.5 decades, though they all share the same general side effect profile, it's become clear to me which SSRIs are likely to induce which unacceptable side effects, and to what degree. Remember that often it's simply a matter of degree. For example, while they all induce sexual dysfunction, some are simply worse offenders. Similarly, while they can all cause weight gain except for Prozac, in my opinion, some unequivocally have a greater propensity to do so. And so what follow are some general profiles, what you might expect from treatment with one SSRI versus another. All of the SSRIs tend to cause diarrhea, headaches, queasiness, restless legs, restless body, which is called akathisia, sexual dysfunction in terms of delayed orgasm or decreased libido, sweating, hot flashes, which is not the same thing, lethargy, yawning not related to feeling sleepy or tired, waking up in the middle of the night, called middle insomnia, jaw clenching / teeth grinding, and weight gain. Sounds terrible, but any list of potential side effects does. The fact is that many of these side effects, if they present themselves at all, are mild and they resolve over time. Most people do not experience most of the list that I just gave. And the last thing I'll say is that there are always exceptions, of course, and you might be that one rare person who actually gets more diarrhea on Paxil than on Zoloft, but otherwise these guidelines will prove true time and again. Prozac, fluoxetine, still the most famous, in part because it was the first, Prozac truly revolutionized the pharmacologic treatment of depressive and anxious mood disorders when it was released in 1987. It was far safer than the first-generation antidepressants available up to then, particularly in overdose, and it induced far fewer side effects. One of the things that distinguishes Prozac from the other SSRIs is that it has an exceptionally long half-life. A drug's half-life is a measure of how long it takes the body to metabolize it away. The longer the half-life, the longer the drug remains in circulation in its original form. Once drug levels have reached steady state, it takes 5 half-lives to clear 98% of the drug. The half-life of most SSRIs is approximately 1 day, so stopping them means that they'll be cleared by the body in about a week. Fluoxetine, on the other hand, has a half-life of 4 to 6 days with chronic dosing. And its active metabolite, norfluoxetine, has a half-life of 1 to 2 weeks. Compared with most other drugs, this is extraordinarily long. The practical implications are that because a drug's half-life also affects how quickly it builds up to steady state with respect to serum blood concentrations, and this is assuming, of course, regular dosing. 1, it takes longer for Prozac to reach therapeutic levels, possibly delaying the onset of action, even more than what's typical for these types of medications, typically around 2 weeks. And even more significantly, when you stop taking Prozac, it can take 5 or more weeks to fully be cleared from your system, although the clinical effects of the medication will begin to wane way before that. One advantage to this is that Prozac withdrawal is not seen. It self-tapers. Abruptly stopping any psychotropic medication, however, is generally frowned upon. But one disadvantage would be a delay in switching to a different medication or starting a new medication that can't be co-administered with Prozac, such as the monoamine oxidase inhibitors, the MAOIs. Ordinarily, you have to wait a couple of weeks anyway before you switch to a monoamine oxidase inhibitor to avoid serotonin syndrome, but with Prozac, you might have to wait a month. Prozac is also known to be among the more activating of SSRIs. It tends to cause jitteriness and motor restlessness, a fidgetiness, a need to move called akathisia. And this is way more common with Prozac for whatever reason having to do with the molecular structure, more so than a lot of the others. Prozac may not be the best choice if you're already troubled with restless legs syndrome or the general inability to sit still for very long periods of time due to motor restlessness. So toe tapping and knee bouncing and just fidgeting and squirming in your seat, and in the extreme, pacing. When akathisia is really bad, the need to move, it's just a subjective need to move where if you can't move, you feel like you're going to crawl out of your skin. It's a very interesting feeling. It's a terrible feeling, but it's on a spectrum of severity. And when it's at its worst, you would see a patient just pacing. Prozac is also famous for what is affectionately called the Prozac poop out. It's actually not at all uncommon for any SSRI after a time to not work as vigorously as it did initially, or even to stop working altogether. When patients have never taken an SSRI, there's always a honeymoon period where just a very little dose, especially for those patients that have endogenous illness, that they're not just reacting to an environmental stressor, they really need the medication. Any patient, even those that are reacting to environmental stressors, will have their thresholds, their tearfulness and anxiety and irritability thresholds manipulated. So they'll all improve and they all experience that honeymoon period, but especially patients who have a chemical aberration, a chemical imbalance, who need more serotonin, especially those patients will go through a period where they get a robust response initially, and when it fades, they're often at a loss. For those patients for whom the medication does kind of poop out, but usually a simple dosage adjustment is all that's needed to jumpstart the treatment. Sometimes a medication switch becomes necessary. I've certainly seen many cases of quote-unquote Prozac poop out, although it's difficult to say based on anecdotal evidence alone whether Prozac is truly more prone to this disappointment than the other SSRIs, or whether we just hear about it more with Prozac. Why a medication stops working or stops working as well over time is a complicated issue that may have a lot to do with extra pharmaceutical factors as well. Fluoxetine, the generic preparation, is also marketed or was marketed in the US under the brand name Sarafem. Sarafem was approved by the FDA for the treatment of symptoms associated with premenstrual dysphoric disorder in adult women. It was the first medication that was approved for that. But it's just fluoxetine. A generic preparation would work as well, and in fact, any of the SSRIs are useful in lessening the emotional lability and the sensitivity and irritability that some women experience due to hormonal shifts that occur mid-cycle during the late luteal phase of a woman's cycle. SSRIs are well indicated for both PMDD as well as milder premenstrual syndromes, and the medication can be taken just during those days because it really has an immediate effect on irritability for sure and fairly rapid effects on the other symptoms. But the current recommendation is that it's better to take a low dose every day of the month if it's tolerated. Zoloft, sertraline. Zoloft was the next SSRI to be developed, and it was just as effective across the board and just as well tolerated as its predecessor. In my experience, Zoloft is not as overtly activating as Prozac, although akathisia is common enough. Zoloft is also one of the SSRIs that's especially prone to diarrhea. Zoloft and Luvox. And you can expect it. I expect a certain amount of, if not diarrhea, GI activation. That's why I always start with a very low dose, 25 milligrams, and to be taken with food. Although the official starting dose was 50 milligrams for the longest time, but that also induced a lot of nausea and headaches. So I think it's really prudent to start at lower doses. Again, start low, go slow. While other SSRIs also frequently cause loose stools, at least initially, except for Paxil, the diarrhea that Zoloft brings on is often more pronounced and often endures for a longer period of time than the others. All serotonergic antidepressants can lead to a certain amount of jaw clenching called bruxism, which can lead to headaches and can be uncomfortable, but it's really dangerous at night when it can cause teeth grinding and dental attrition. You can really wear your teeth down. Perhaps because it also has very mild dopaminergic activity, Zoloft is especially prone to this side effect, more so than the other SSRIs, and particularly when it's combined with a stimulant medication such as Adderall or other stimulants used in the treatment of ADHD. It can be a dental emergency, and if it's happening, a person should wear a night guard. Most of us should wear a night guard anyway, according to my dentist. Unlike Prozac, which is often started at the target dose of 20 milligrams, Zoloft I started at 25 milligrams, which is a subtherapeutic dose for the vast majority of people. 20 milligrams of Prozac is a therapeutic dose for most people, and you don't have to change it for most people unless you're treating anxiety, and then the target dose is closer to 40 to 60. But 25 milligrams of Zoloft for the vast majority of people is subtherapeutic. Thus, it requires more of a titration to reach the recommended dose, which could be eventually as high as 200 milligrams for some patients, depending on the target symptoms and their volume of distribution. With each adjustment, side effects like diarrhea can reappear even after they had previously resolved, although this effect does become attenuated over time as well. So you reach a point where you're not going to get any more loose bowel movements no matter how much you increase the dose, because you've effectively downregulated serotonin receptors in the gut or wherever we're talking about, and you're just not going to get that side effect anymore because you're immune to it. In general, the more dosage is tolerated, the less increasing that dosage will further renew old side effects. And that's true of all the SSRIs. Plenty of patients have noticed weight gain on Zoloft. In my experience, it's certainly not the worst in this regard, but it is possible. Paroxetine, Paxil. Paxil is the most potent inhibitor of serotonin reuptake in vitro. Clinically, I've found it to be the most aggravating in terms of sexual dysfunction. but it's also probably one of the most effective, and I certainly think about it in my patients with OCD, or the patients with panic disorder, or who have severe endogenous illness and can tolerate a little sexual dysfunction. Many patients report complete anorgasmia even on starting doses, 10 milligrams or less, which makes low-dose Paxil an excellent treatment for premature ejaculation. But it is something of a problem in treating depression and anxiety, particularly at the higher doses recommended for those conditions. Paxil is unusual among SSRIs in that it is somewhat anticholinergic. That is, it blocks one type of acetylcholine receptor, the muscarinic receptor, that's normally bound by acetylcholine, and the result are side effects like dry mouth, constipation, blurred vision for close objects. This is due to impaired accommodation, similar to presbyopia, older persons who need reading glasses or computer glasses. You can also see tachycardia, an elevated heart rate. You can see urinary retention, which can be a problem for some older patients, particularly older gentlemen who already have a certain degree of benign prostatic hyperplasia and who might have problems with urinary retention as it is, or patients that are on other medications that also cause those side effects, and so you might get a synergism. But they are mild compared to most other anticholinergic drugs, so it's all relative. But it really is the only SSRI that has significant anticholinergic activity. Anticholinergic side effects can also include a subtle impairment in short-term memory. Well, this may not be so subtle for patients who are older due to blocking acetylcholine in the hippocampus, and that's the part of the brain that's mostly responsible for short-term memory. For this reason, Paxil is usually a poor choice for an elderly patient who may already be experiencing significant problems with constipation, super common in the elderly, presbyopia, which is 100% of people over age 50, and noticeable short-term memory loss. Even if they don't have Alzheimer's, a lot of seniors, especially those who are over 80, have a certain degree of age-related cognitive decline that may be noticeable. It might not be clinically relevant, clinically significant, where it actually disrupts the lifestyle and it causes impairment, and it might be a focus of treatment. It might just be noticeable. You're just not as sharp as you were when you were in your 20s. And so I don't use Paxil for my geriatric patients because of this, because it's got too many side effects in that arena where they've already got problems there. So we don't want to compound those problems. And while all of the SSRIs can potentially lead to weight gain, except for Prozac, in my opinion, Paxil is one that I consider notorious in this regard. I completely avoid it in patients for whom this is a particular concern. And then I think Lexapro would probably be the next one, and then finally Luvox and Zoloft. Unlike Prozac, Paxil is also one of the SSRIs that is associated with a peculiar discontinuation syndrome. And I call it a discontinuation syndrome as opposed to a withdrawal syndrome, purposely to avoid the notion that Paxil is in some way addictive in the classic sense, which it is not. But I did have a viewer who took issue with this and had very interesting discussion, and it's in the comments section on the Paxil video, and I encourage you guys to check that out. He made some good points that it really is a withdrawal syndrome. It's semantics, whatever you call it. It is what it is, which is if you abruptly stop taking the medication, you have a bunch of physical side effects that are very unpleasant. Dizziness and headaches and malaise and maybe GI disturbance, cramps and upset stomach and so-called brain zaps. They're paresthesias. They occur especially if you turn your head too quickly and you just kind of feel this weird feeling in your head. It's very hard to describe. But at its zenith, at its worst, it feels like there are electrical zaps in your brain, like you're having electrical firing going on. And those are called paresthesias. or dysesthesias, which just means weird or abnormal feelings, is what those words mean. And they're harmless, they're not dangerous at all, and this withdrawal, I'll call it withdrawal for the sake of acknowledging what this viewer, the points he was making. But the point that I want to make is it's not dangerous, as unpleasant as it is. It's going to get better, and it's not going to harm you in any permanent way. And it can be avoided by weaning the medication, by down titrating it, lowering the dose slowly over a period of days to weeks to months, however slowly we need to do it. And you can also use benzodiazepines and other medications to take the edge off of some of these side effects and to get patients off of these medications. But they're not habit forming. Well, again, semantics. I mean, you could certainly call that habit forming. When we say habit forming, though, what we're talking about is you have to take more and more of it to get the same effect. That's not true of Paxil. It also has no euphoria with it unless you have bipolar disorder and you're taking the antidepressant and it's causing euphoria because you're bipolar. Even in all bipolar patients, it doesn't cause euphoria in all bipolar patients, but it can. But it's not like it gets you high, and it's not like you crave it. It's not addictive in that sense. It's not addictive in the sense that you have receptors that you're down-regulating. You down-regulate serotonin receptors, but that's down the line, and that occurs with all SSRIs, including Prozac, which does not have a physical withdrawal. And that's just your body's response to having elevated levels of serotonin, which is what these medications cause. But it's not like benzodiazepines, like Xanax, where you take it, it gets you high, it makes you feel good, but then your body downregulates benzodiazepine receptors that respond to benzodiazepines, and you have to take more of the medication to get the same effect, even to just feel sleepy. And then when you stop taking the medication abruptly, because now you've downregulated your receptors, now there's not enough receptors, there's not enough GABA. It gets a little esoteric, but the neurotransmitter that also binds to those receptors, there's enough of it, but there's not enough receptors now because you've downregulated. And so you get an activation of the central nervous system that can range from anxiety to tremors to seizures to status epilepticus and death. It can kill you. And so that's the only reason that I sometimes call this syndrome of abstinence, that's how you say it in Spanish, síndrome de abstinencia, which means abstinence syndrome. That's why I sometimes call it a discontinuation syndrome. But this viewer really had a very good point. It does cause withdrawal, which can be miserable. And you also never want to abruptly discontinue a psychotropic medication because you can get rebound symptoms, including especially rebound irritability in the short term, and that's almost for everybody. You don't necessarily get rebound depression unless there's endogenous depression that's underlying, but you definitely get rebound irritability, you get rebound anxiety with these medications. And so to avoid that and to avoid the unpleasant physical abstinence syndrome, you got to reduce the dosage. That's just the smart thing to do. And that's just due to the particular neurochemistry of paroxetine. So even for some people, taking medications just a few hours later than scheduled can lead to this dizzy, flu-like symptoms and the paresthesias, especially venlafaxine, Effexor. There are patients that tell me that sometimes if they forget to take their medicine, they're reminded that same day because they start to feel those weird feelings in their head, those paresthesias, tiny lightning fast electric shocks or brain zaps. But that does not represent seizure activity, and they're more uncomfortable than harmful, and they do eventually subside. This can happen with Luvox, this can happen with Zoloft, but it tends to be much worse with Paxil for whatever reason. It's important to note that these withdrawal paresthesias, these brain zaps, they don't wake people up from sleep. And so when the brain is idling, when you're sleeping, you don't have them. And so taking a low dose of Xanax, for example, or Valium can also assuage this particular side effect. So the way to avoid them is to avoid abruptly stopping medication. That's always ill-advised. Always the recommendation is to lower the dose gradually over several days under a doctor's supervision before stopping. If you're going to go out of town, you want to take extra precautions not to leave your Paxil behind, and you want to avoid getting caught between refills for the same reason. With all of its extra tolerability issues, Paxil is often clinically superior to the other SSRIs in certain conditions that require truly potent serotonergic medication. I myself have seen it outperform the other SSRIs, even at maximal doses, in generalized anxiety disorder, in obsessive compulsive disorder, in particular panic disorder, social anxiety. Paxil definitely has its place. Luvox, fluvoxamine. Luvox is not as well recognized among laypersons, due in large part to the fact that it was originally approved and marketed for the treatment of obsessive compulsive disorder, which is not as common as other anxiety disorders and major depression, but as repeatedly stated, all of these medications are useful for all of the same types of depressive and anxious mood disorders. Like Paxil, Luvox is associated with a pronounced withdrawal syndrome, if not gradually tapered before discontinuation. And like Zoloft, Luvox typically has to be titrated from a starting dose to a significantly larger final dose and is more likely to cause GI disturbances than the others. Either loose stools or alternately, interestingly, it can also cause constipation. It also might have to be dosed more than once a day, unlike the other SSRIs, to get the smoothest blood levels and the best efficacy. Weight gain is another not uncommon issue with Luvox. Celexa, Lexapro, citalopram, escitalopram. Whereas Paxil is the most potent selective serotonin reuptake inhibitor, Celexa and Lexapro are the most selective, referring to their relative effect on serotonin receptors versus other receptor types. And as a matter of fact, Lexapro has virtually no other pharmacodynamic interactions. It is extremely selective. And among SSRIs, their action is the most specific to serotonin receptors. Lexapro, escitalopram, is the left-handed stereoisomer of citalopram. And that has to do with organic chemistry, its stereochemistry, the idea of enantiomers. I explained that in the Celexa Lexapro video. And by the way, there are at least one video on all of these medications. Check out my psychotropic medication A to Z playlist for videos on all of the above in detail. But escitalopram is the biologically active molecule. The right-handed enantiomer, R-citalopram, is not only inert with regard to blocking the reuptake of serotonin, but actually competes with S-citalopram, so that by removing it from the mix, the racemic mixture, which is what Celexa is, it has both right and left. So Celexa contains Lexapro. Lexapro can be thought of as the purified form of Celexa. By removing the R enantiomer, both potency and efficacy are increased. And so you can use lower doses, and even though you're taking 50% of the molecules out, the ones that are not biologically active, you often get sometimes as up to a 4-fold increase in the efficacy on a milligram per milligram basis. And that's because the active component is not competing with the inactive component for receptor sites. If Paxil has the worst sexual dysfunction, Lexapro typically has the least. So I do think of it in my patients who are particularly concerned about sexual dysfunction. However, like Paxil, Lexapro frequently causes significant weight gain. Effexor, venlafaxine. So Effexor is actually a dual-acting agent. It was the first commercially available non-tricyclic serotonin norepinephrine reuptake inhibitor, SNRI. SNRIs can be advantageous over SSRIs based on their dual mechanism of action, and indeed have been shown to be somewhat more efficacious with respect to treating depression. They may also have a more rapid onset of action, which I have certainly seen with Effexor in many cases. I include Effexor in this discussion because at low starting doses, Effexor is essentially an SSRI. Its reuptake blocking activity is more potent for serotonin than norepinephrine at all doses across the board, and at very low doses, the noradrenergic activity, the norepinephrine reuptake blocking activity, is clinically negligible. The affinity of venlafaxine for serotonin reuptake blockade is many orders of magnitude greater than that for norepinephrine, and noradrenergic reuptake does not occur until you reach those higher doses. Effexor's side effect profile is very similar to the other SSRIs, with significant sexual dysfunction and a marked discontinuation syndrome. As a matter of fact, in my experience, the most severe withdrawal, not the most severe, Paxil tends to have the most severe, but Effexor is also really bad, and it comes on really quickly, maybe more quickly than Paxil, but maybe not as bad. It's different from person to person. It really depends on the dosage as well. But the other thing about Effexor, there's a lot more temperature dysregulation in patients taking Effexor, and that's hot flashes and night sweats, which are really the same thing. Temperature dysregulation is not increased sweating. It's not just hyperhidrosis because you're exerting yourself or because it's hot outside. That happens too because of increased norepinephrine. But this is because of the increased serotonin, and it's analogous to the hot flashes that menopausal women experience. They experience it because there's estrogen withdrawal that's causing it. This is a different mechanism, but it's the same clinical manifestation, which is the temperature's fine, it hasn't changed, everybody else is comfortable, and suddenly you break out into a copious sweat. You can be drenched. There are different degrees of it, of course. But when it happens at night, throughout the night, and you're sleeping, you got the covers on, you can wake up and sometimes the sheets are soaked, and those are called night sweats. And Effexor causes it much more than any of the other serotonergic antidepressants. And I really have never seen weight gain on Effexor. Other considerations that come into play in choosing one SSRI over another may be practical. Whether or not the medication is supplied in liquid form for those patients, children usually, who have difficulty swallowing a capsule. Most of the SSRIs are also available in extended release or controlled release preparations, which, although their development may have been prompted by corporate financial interests, can nonetheless be very useful at reducing immediate side effects by prolonging absorption and simplifying a regimen to once a day that you might otherwise be taking in divided doses throughout the day. Although I still think it's a good idea to take medication with food initially. One other point bears mentioning in any discussion regarding psychotropic medication selection, and I've already mentioned it, and that is family history. If you have a blood relative, particularly a first-degree relative, such as a parent, sibling, or child, who responded favorably to a particular medication, you have a statistically higher probability of responding favorably to that medication yourself. So, inasmuch as selecting a psychotropic medication can be an empiric trial and error process, be sure to mention that to your prescribing doctor if you know about it. Thanks for listening, and please stay tuned for more great content.